Hi, is anyone else on here?
Yes,
Oh, hi. How are you guys doing
Yes.
today?
We're
Okay.
Very well.
good.
Mhm.
Okay, good.
Good.
Looks like I got quite a few of you guys on here. And did you get my email sent out yesterday by around 1 o'clock?
Yes,
Yes.
we did.
yes.
Oh, good.
Pausane dákẹ́. Ah,
Well, I'm going to ask you to go ahead and mute yourself unless you're going to ask a question. I have got my chat up so I can see chat. And I'm also recording this so that I can go ahead and add it to the SharePoint just in case someone was unable to join us. So hopefully we'll be able to um, share our information with everyone. Let me go ahead and pull up the whiteboard here. You guys get quite a bit of snow yesterday.
I think I got like 6 inches.
Yeah, I think that's about what we got also out here. Well, what I'm going to do is go ahead and pull up the email I sent out yesterday, and that's a good review of the final exam and all the topics that are on it. Um, we'll just go through that. If you have questions or if you don't understand something, I'll try to do my best to explain it, and we'll go from there, okay? All right.
Okay.
I'm going to go ahead and share my screen so that you can see the same notes that I have. And so you should be able to see the
I'm gonna call you the
email
video
that I
with
sent
questions here
out.
because I agree.
Again, if you could please to go ahead and mute your audio so that you're not sharing anything background unless you have a question. Again, I do have the chat up, so I will be happy to answer that. So, oh, just to jump right on in, the first part of these notes that I've sent out are the medications that seem to be on the exam. Make sure that you know these, you know the other medications and how they work. Warfarin, heparin, Lovenox, Eliquis, and rivaroxaban, of course, are our uh, anticoagulants. Those are going to be in different questions in different ways. You need to know which ones are oral, which ones are sub-Q. So you know that heparin and Lovenox are sub-Q delivered, whereas warfarin, Eliquis, and rivaroxaban are oral. Warfarin used to be also known as Coumadin, but we no longer have to worry about that because they've gotten rid of that drug and have replaced it with some others that are in the warfarin family made by other companies. The company that made Coumadin decided that they could not make enough money with it, so they dropped that drug. But we're still using it a lot in our notes. And so I apologize for that because we still know it by that particular name. Uh, You know that the side effects of warfarin is, of course, increasing your bleeding time. It's going to cause you to, thin out. We use warfarin and our anticoagulants for treatment with DVT, PE, etc.
And she's married. Her
Okay,
boyfriend doesn't do anything.
I can hear someone's story about their boyfriend. You might want to actually mute your phone unless you want everyone to know what your stories are. So let me see here. Uh, Here we go. I'm going to go ahead and mute you all. If you have any questions, please make sure you just put up your hand, use the chat board, and I'll unmute you at that time because I just don't want you guys sharing any personal information because I am recording this, so other people are going to be able to hear this. Again, going back over anticoagulants, your anticoagulants treat DVT, PE. They use it a lot in patients that are immobile. So if they've had surgery and they've not been, they're going to be on bed rest for a few days, they put them on heparin or Lovenox sub-Q to keep them from developing blood clots. We also should make sure that they have TED hose and SCDs on at that time. Need to know your medications and which ones are going to be sub-Q, which ones again, your sub-Q medications that usually are in these are the insulin, heparin, and Lovenox. So make certain that you are able to answer those questions. Let me see what else here. I'm trying to check to see if there's anybody else that needs to be let in. Okay. All right. I'm sorry for my quiet for a few moments here. All right. Going on down the information that we have on our review topics. We also have intradermal injections. Remember the intradermal, they're given at 5 to 15 degrees. The intramuscular is going to be 90. You're going to use a longer needle with those, smaller needle with the intradermal because we're only wanting it just under the skin. An example of intradermal is you're going to be the TB test or the MAN2 test that we give in order to check to see if you have tuberculosis. The most rapid onset of any of our medication delivery systems, of course, is IV because it's immediately into the system. So make certain that you're aware of that. Drug schedules, I want to hit that real quick also. The DEA categorizes medications based on their potential abuse. You can go to the website that I've got here on the information and actually look at schedules. It's just this one here that I'm highlighting. And that particular website will tell you which ones are Scheduled 1. What Scheduled 1 I cannot, as a nurse practitioner, prescribe because they have the highest abuse. Only certain physicians that have received approval from the DEA directly can actually prescribe those medications. But Schedule 2, yes, we can. And that's the MS Contin, morphine, oxycodone, fentanyl. Then some of your barbiturates are in that list as well. And some of your antipsychotics, et cetera, are in there. The slowest route of administration is oral. And oral medications, of course, are through the mouth, or we give that through NG or PEG tubes or through G tubes. And in that instance, they have to be able to be crushed. Further down, I do have a list of information on making sure that you guys know which medications you can actually crush and which ones you cannot. Can you delegate application of moisture barrier or skin moisturizers to a unlicensed person? Yes, you can, as long as they have demonstrated their use, how to use them to your satisfaction. Since you're going to be the licensed person, you have to know who you're delegating to and whether or not they are capable of following those delegation rules and your directions. If they cannot, then you should not be delegating to that person if you're not for sure if they can, follow your orders. And of course, and your responsibility after delegating is to make certain that you follow up with that person and make sure that they have completed the task that you've assigned them to your satisfaction, because you're going to want to make sure you document that that task was completed. All right. What medications are for osteoporosis? Make sure you know that we use calcium supplements. Vitamin D is used in order to help the calcium to be absorbed. Fosamax, that is a medication to help with bone strength. Some of those medications, like Fosamax, can be delivered once a month. They have some bone osteoporosis meds that are just once every 3 or 4 months or every 6 months. They're injectables, and they also need to have good follow-up as far as lab tests, making sure that their calcium, phosphorus, and vitamin D levels are within normal orders. Remember that BPH, which is benign prostatic hypertrophy, that is the prostate, ladies, that is only in men. It's treated by two drugs, and everyone seems to want to get these mixed up with Fosamax. Flomax is the actual medication that keeps the flow. So again, remember, keeping the flow is Flomax and Proscar. That helps decrease the prostate size, and it helps basically men urinate. We're also using these medications, Flomax, etc., in order to actually giving them to women. I have prescribed them for a woman that was on long-term Foley catheter, and she had been unable to urinate, so we gave her Flomax, which seemed to help, and that was good. It got her back to urinating on her own without the need of having the Foley catheter. Let's go on down here for a moment here. Alendronate, again, is on here a second time. The reason why I put it there a second time is to, again, don't get it confused with Flomax. Fosamax, again, should be taken in the morning with a full glass of water for our osteoporosis patients. Make sure that it's on an empty stomach. When you're prescribing pain medications or delivering pain medications and the person has asked for pain medications, make certain to do your PQRST. That way you can evaluate whether, which medication is going to be appropriate. The physician will have, or the provider will have given you quite a few orders on different types of meds. Typical pain meds include Tylenol, opiates like Narco, Lortab, and morphine. Those do not treat inflammation, but your NSAIDs do. So make sure you know the difference between NSAIDs, non-steroidal anti-inflammatories. And again, Tylenol is not a non-steroidal anti-inflammatory. It is an analgesic or a pain med. So it does not treat inflammation. Your NSAIDs are going to be your ibuprofen, Motrin, Aleve, Toradol, ketoprofen. Those are going to be your anti-inflammatories. Your physician will have given you some medications for severe pain treatment, especially if they've had surgery of some sort, and then they're going to also give you a medication that is for more moderate pain and then for pain that's more mild. And it's up to us then to determine, based on the patient's pain report and location and what symptoms they're having with the pain, to decide which medication is appropriate for that patient's use now, and whether or not they've had pain medication just recently. If they have had recent pain medication, then maybe they're having breakthrough pain, and then we need to do or use something different. So as you can see here on the notes, we have severe pain. If they have pain from 8 to 10, and that's going to be based on that order again, the doctor will have written morphine 1 milligram IM every, let's say, 2 hours for pain 8 to 10. And then they may have written Lortab or Narco for mild or moderate pain 5 to 7. And then mild pain 1 to 3 would be or 1 to 4 of that sort for their ibuprofen, NSAIDs, or Tylenol. It's very important that if the patient gave you a pain level of 5, not to give them a medication like morphine if that was the level they gave you. Because they're going to say, your manager, the physician, State Board of Health is going to review those. And if the pain medication that you're putting down as the report doesn't match what the doctor's ordered, then you are not following orders. So make sure that you're providing the appropriate medication for the appropriate pain level at the appropriate time. So make sure you're following your rights. Again, there's number 12. It's talking about the NSAIDs, non-steroidals, and then right underneath it is a discussion a little bit about deltazone. It's a form of prednisone. That is used in the treatment of Addison's disease. If you have a patient that's coming in with Addison's crisis, meaning they're under stress, when they have stress, then their body can't handle it because they're not actually secreting cortisone. They need to have IV fluids. They're going to be dehydrated a little bit, and then we give them deltazone or prednisone in order to give them the cortisol that they are unable to produce themselves. Do not give prednisone or deltazone or a steroid to a patient with Cushing's because that's the one that already has the steroid. You can actually push them into a Cushing's like coma if they get too much steroid. Okay. What is a common cause of constipation? That's going to be your narcotics that cause constipation. Let me also go up here. And I want to also see my chat screen here. Moving my chat screen over because it's in my way here for a moment. No, NSAIDs do treat Candy, your inflammation. They are the correct medication we give for inflammation. Okay, getting back to knowing your narcotics that cause constipation, make certain that we are treating that patient with some stool softeners automatically, and then that we have an order for laxatives if needed. Remember that stool softeners add water to to our system. It allows us to hold on to water in the colon. The colon's job is to remove water from the stool and the food that we eat as it's being processed, so it will be compact, and then we can eliminate that. Our nutrients are absorbed in the small intestine, but we need that water. That's the reason why docusate sodium is so important for us to keep that patient from being constipated. And then we can add a laxative if they are still having further constipation. Number 15, as you can see here, is the ones on do not crush. Know that your XRs, especially like Lopressor XR is an example of an extended release medication. We cannot crush that if we're going to be putting it into an NG or a PEG tube or delivering it to a patient that cannot swallow. If you have one of those medications, the appropriate first step is to go and get an order from your doctor for a different medication so it can be replaced. There's a lot of different replacements we can use instead of Lopressor, which is metoprolol tartrate. We can go to metoprolol succinate, which is not extended release. PCA pump, I'm going to talk about this because we didn't do a lot of talking in our lecture about PCA. PCA is patient pain control analgesia. That's a pump that we set up for the patient that has a specific medication for pain, such as Duramorph or Dilaudid or morphine. The doctor will give us specific directions on how often it can be given, and we give the controller to the patient. The patient will then use the medication as they are having pain. If the family starts trying to give the patient pain medication because they're sleeping and they think they're having pain, don't let them do that. That's not the correct use of that machine. The machine is for the patient. That's the reason why we call it PCA, or patient-controlled analgesia. If we have a family that's using that, then we need to make certain that we do some reteaching and explain to them that oversedation of that patient can actually depress their respirations and they can harm their loved one. And we don't want them harming that person. If for some reason they can't abide by that, then maybe that patient isn't an appropriate patient for a PCA pump. So then we would decide, oh, let's just get rid of the PCA pump and use medication that we're delivering for the patient when they're asking for it. I've never had a patient's family, after being explained this, to cause any more issues with that. Usually they stop. And then you just check from time to time. So let's move on down to our topics. I try to divide these up into topics and try to get AI to help me sort my notes after I had them done, just so that they would be at least in some order. So some topics are at least together. Doesn't mean that it's the way it's going to be on the exam. So, but this makes it easier, I think, for studying if we put like topics together. Respiratory hypoxia. Okay, so we're talking low amount of oxygen in the system. There are signs and symptoms of hypoxia. You do need to know these. Everything that I've put in these notes are things you need to know for the test. So there's no need for me to say you do need to know this. You all know that you need to know everything that I've got listed here. Pallor, hypertension, dyspnea, bradycardia, restlessness. Those are all important things for you to know and to be able to recognize when answering those questions. We also then check the oxygen and make sure you're checking it with a pulse oximeter or a saturation monitor. If you're in the ICU, that's usually on the screen along with their EKG, respiratory, and their blood pressure, et cetera, so we can keep an eye on their vital signs. Respiratory, again, topic, COPD and emphysema. COPD is chronic obstructive pulmonary disease. Emphysema is the actual destruction of the alveoli caused by long-term smoking or other types of inhalants, where it's actually the alveoli are destroyed. When we look on a CT scan or we look on the X-ray, we can see that, and we can see that damage on the CT scan. So we know they have emphysema. Never, and I'm going to stress this once more, never use more than 3 liters. Your question's going to ask you, how many liters can a COPD or emphysema patient have? And you're going to have to know that no more than 3 liters. We know that a registered nurse can automatically put the patient on 1 to 2 liters, but we never want to go above 3 liters without talking with the doctor and saying, hey, this person has COPD and emphysema. Are you sure you want me to put them on 5 or 6 liters? Again, also know that if we put them on more than 3 liters, it may hinder their respiratory drive, and that will result in respiratory difficulty, respiratory depression, and difficulty breathing. For oxygen safety, make sure we keep those oxygen tanks upright. We should limit how many are stored together. We also need to put a sign outside the home on the front door that oxygen is being used inside the room or in the home, and also which room that person's oxygen is in. The reason why we do that is because if there is a fire or if there's an EMS call to that home, the fire department appreciates knowing that that person has oxygen delivery. The police also like it. We also do that because if there's an electrical outage, then the people that work on restoring electricity will know that that person needs that electricity and they're a priority. A person using oxygen should also let their electric company know with a letter from their physician saying that they are a priority response home and that they need their electricity restored as a urgent need because they're on oxygen. They should not smoke around oxygen, also to keep the oxygen away from flames and open flames, heat sources, etc. They should drink fluids to keep themselves hydrated so that if they're using oxygen, and oxygen can have water added to it or saline, or it's usually distilled water that we add to it, distilled water in order to keep it moist. We never store, again, oxygen near a heat source. Oxygen delivery methods is nasal cannula. The nasal cannula is the one of the prongs that go into the nose, never above 6 liters. 6 liters is the max. Simple mask, we can actually provide a higher flow of 12 liters, 15 liters if necessary with a simple mask. If your physician orders a specific amount of oxygen, then that's done with the Venturi mask, 24, 28, 31, 40, 50, etc. And it's the one that has the little color-coded plastic concentrator devices that we put on the oxygen. It mixes room air with the oxygen to deliver a specific amount of oxygen. And then, of course, then your non-rebreather has that bag attached at the bottom. The non-rebreather that bag must be actually filled with oxygen first. What we do is you occlude the oxygen going into the mask, allow the oxygen to flow into that bag, and then we place it onto the patient's face. Again, it can deliver up to 90% oxygen. Make sure the tubing is not crimped or impaired or stepped on or somehow another occluded, because if you occlude the oxygen tubing going to the non-rebreather, that person has the vents that are on there. Those vents keep them from adding more oxygen to the mask, and they actually can suffocate, because if you put your hand over your mouth and you can't get air in, it's like putting a plastic bag over your head and wrapping it around your neck. So you don't want to do that. You want to make sure that the non-rebreather is free and that it's flowing, and make sure you check your patient quite often if they're on a non-rebreather. Of course, the first thing to do for patients that are having difficulty breathing is to set them upright, get them into a high Fowler's or semi-Fowler's, and make certain that they have good oxygen flow and that they're pinking up, evaluate them for cyanosis, etc. Check their capillary refill, check their pulse ox. Okay, asthma. The breath sound we usually hear with asthma is wheezing. The treatment for asthma, albuterol, ipratropium, or bronchodilators. Number one teaching that we need to make sure that we're providing is that don't overuse. It can cause the person to have tremors, restlessness, tachycardia. It can lead to trouble breathing if overused. Assess the patient for overuse of their inhaler. I mean, when you're going in to assess them and you know that this person has use of nebulized medications and they have their albuterol. If they have tachycardia, meaning a high heart rate, they feel tremors and tremulous, then that could be a problem. So we want to make certain that they're not overusing their albuterol or ipratropium bromide or their levobuterol. I'll get that out today yet. So we want to make certain that their bronchodilators are not being overused. When we tell a patient to use their inhaler every 3 to 4 hours, we mean only every 3 to 4 hours, not every 3 to 4 minutes. If we say nebulizers every 6 hours, that means every 6 hours. If they double up on that, then they're actually going to depress their ability to breathe, and that's going to also cause respiratory depression. So that's the reason why we don't do that. So let's talk about cardiovascular. Let's talk about the word insensible, INSENSIBLE, as you can see spelled here on the screen. That means water loss that we're not able to measure. We know we're losing it, but we don't know how much it is because it cannot be measured. So insensible water loss is that what we lose when I'm talking. I'm losing water with me talking. When I breathe out, as we can know that we can see moisture on a mirror. If I put a mirror in front of my mouth or my nose, you can see that the water vapor is accumulating there. We also have other areas that if we cry, that's insensible. If we sweat, that's insensible water loss. So we have 3 areas. It's tears, perspiration, and water vapor from our lungs. So those are some examples of insensible water loss. The rest of the water loss that we lose, like from urine, from emesis, from diarrhea, those things we can measure. So those are not insensible. Again, cardiovascular fluid volume, talking about fluid volume here. Symptoms associated with fluid volume excess, meaning too high of a volume, meaning that they have hypervolemia, is that they're going to have high blood pressure. They're going to have crackles in their lungs. They're going to have, I guess I need to use this. They're going to have sometimes swelling in their feet. They're going to have changes in consciousness. Again, here's their hypervolemia, crackles in the lungs, increased lung fluid in the lungs, changes of the level of consciousness. Both hypovolemia and hypervolemia, you're going to have changes in level of consciousness. But the big one is your high blood pressure versus swelling in the arms and legs. And those patients that are at risk for having too high a volume, of course, are end-stage renal disease because their kidneys are not working. They're holding on to urine. They're not getting rid of the excess fluid that they have. And then our heart failure patients, they're the ones with right heart failure. We're seeing swelling in their ankles and legs, and then left-sided heart failure, we're seeing back up into the lungs. So those are the ones that are really at risk if we give too much IV fluid, or if they're drinking, large amounts of water, more water than their body can handle, then that's a problem. Then also clients with cirrhosis of the liver also are at risk for high volume. Okay, let's talk about, we're going to talk about real quick here, fluid volume deficit or hypovolemia. With low blood pressure, that's the low, okay, excuse me. If they have a deficit or hypovolemia, that means that they could have low blood pressure, dehydration, changes in level of consciousness. Are you guys hearing me okay? I just had an alert from my internet provider that yeah, there you go. I see that we are cutting out. Hey, Dennis, I'm cutting out down here. Don't use the internet. Tell my husband to get off the internet so I can make sure I keep mine. I'm losing my internet. Could you please not use the internet for a little bit more? Okay, looks like we're better now. Thanks, Miss Davis. I appreciate that. Okay, don't use the internet. I'm losing internet. Okay, going back to deficit, hypovolemia, low blood pressure, dehydration, again, changes in level of consciousness or both with high and low. And our volume loss could be due to blood loss or fluid loss. Remember that our body will try to rebalance the fluid loss by increasing our heart rate to increase cardiac output, and that's to keep us alive. It's a safety mechanism with our body. Those with who are at risk for low volume, again, cancer patients who are receiving chemotherapy, they may be experiencing hyperemesis or diarrhea. And yes, I can share that this document. I've shared it with everyone in Indianapolis. If you leave send your email address, and I'm going to just type it here. If you send your email address to me, I'm just typing it in here, andros.edu. I will get you a copy of this document today as soon as we get off, okay? So let's go ahead and talk about treatment of high potassium. If we have patients that are having hyperemesis and diarrhea, they're going to lose their electrolytes. And I don't know why this doesn't have as we were talking about, wonder why this is saying this and not potassium. Okay. If you guys have, for some reason, this has not got my information on high potassium. The treatment to high potassium is going to be Localmia, Kayexalate that causes diarrhea. Remember that insulin can move potassium from extracellular compartment to intracellular, and we have to make sure they have D5W or dextrose containing fluid to keep them from having hypoglycemia. So let's talk about, again, some high potassium. If you have your Saunders, fluid and electrolytes is in chapter 8 in Saunders. Some of you that don't have access to Saunders right now in Indianapolis, I've tried to add the information for from the Saunders so that you guys can hear it again. Remember what the levels are for potassium. I'm going to go ahead and put potassium here. So anyway, potassium is 3.5 to 5.0, and that's MEQs per liter. We know that with low potassium, we're going to be that's life-threatening. Both low potassium and high potassium are both life-threatening. And that can cause issues if we don't treat it quickly enough, if we don't recognize that the person is in either too low a potassium or too high a potassium. If you recall, potassium can be too high because of medications that we use, like spironolactone, which saves potassium, or if the person is adding potassium chloride to their diet. Too low of potassium is because we're using a loop diuretic like Lasix or furosemide, and it may not be adequate amount of potassium, so we have to make sure that they're supplemented with potassium. Let's go on down here to electrolytes. Then we're going to discuss here with calcium. So remember that our low potassium is and high potassium levels. So 7.5 is our threshold to 10.5. If we are above 10.5, that's hypercalcemia. We're going to see diminished reflexes, increased heart rate, and then later they'll have bradycardia as the heart doesn't like to have that as the calcium climbs higher and higher, we get sluggish muscle response. The muscles become weak. The person will have disorientation, lethargy, and in late symptoms, they'll have coma, anorexia, nausea, abdominal distension, constipation, and EKG changes. So I appreciate you guys emailing me direct, because when I get off here, I lose my chat and I won't get to see your email addresses. So make sure you email those to my address, and I'll be glad to copy and paste this in or to attach it and send it to you. Hypocalcium, that's calcium less than 7.5. Remember, Chevotix and Trusosine are both going to be positive when the calcium is too low. And we also see that Chevotix and Trusosine, because remember, calcium and magnesium follow one another. When calcium is low, so is magnesium, and magnesium will also be exhibiting the Chevotix and Trousseau's. It will also be showing hypotension, anxiety, irritability, hyper increased reflexes. With low magnesium, you raise that person's foot and it starts shaking all over the place, so that you know that the magnesium is out of whack, and so is the calcium. So we need to be watching for twitches, cramps, and seizures. Increased GI motility, so they possibly could have more diarrhea. There's our hypokalemia and stuff. I thought I had this in here. I must have had it in two different places. Again, like I said, I was trying to organize these notes, but because the questions that I was reviewing were all over the place, and so were my notes at one point. So electrolytes, hypocalcemia or hypokalemia. Here you have your low potassium. Again, low potassium is going to be less than 3.5. So hyperkalemia is more than 5. Both can kill. The higher that goes or the lower it goes, it can cause all sorts of problems. So make sure that you're reviewing that and that you've got those in your head. You know that if we are too low of potassium, we're going to give potassium chloride. Make sure that when you're giving diuretics with these patients, that you're also assessing their electrolytes. response? Are they having problems with cramping? Are they having problems with vomiting, diarrhea? That you're going to see these patients have their electrolytes are going to be skewed. If we have prolonged nasogastric suction, meaning you have them on suction to the NG and the NG is pulling out all their acid from their stomach, it's also going to lower their potassium as well. They will have excessive sweating and diaphoresis, also is going to be seeing some low potassium as well. And if they have kidney disease, you're going to see low potassium because they're not reabsorbing the potassium through their normal um, um, filtration of the kidneys. Okay, which electrolytes? Okay, which foods are high in sodium? If you have a patient that is needing to add sodium back to their diet, that's great. There's a lot of foods out there with salt in them. But if they have to limit their sodium intake, such as with congestive heart failure, then we need to know that they should not be eating hot dogs, especially anything that's processed that's got nitrates added to it. If it says smoked or cured, it's going to have high sodium because they smoke and cure it with sodium. There are some more natural meats that are processed that don't have a lot of sodium. It'll even say low sodium on them. Canned vegetables are usually preserved with salt. So your canned corn, canned green beans, unless they rinse them, they're going to have sodium added to it. So they don't need to be adding salt to those. Our normal congestive heart failure or cardiovascular patient will be limited to 2 grams or less of sodium per day. That's a lot of, that is a very little amount of salt. And the reason why we limit their salt is because salt holds on to water. Water follows the sodium. And if they have too much salt in their system, the water is going to stay in their system because it's trying to dilute that out. Therefore, they end up holding onto the fluid. And of course, in congestive heart failure, that's not good because now they can't breathe. Electrolyte sign of calcium imbalance. Again, we've got the Chevautex, trousseau sign, muscle spasms, tetany, decreased heart rate, hypotension, diminished peripheral pulses. And I said I was sorry that some of these electrolyte things, they ended up being in different places with one another. You may have to sort these if you want to copy and paste and move them around so that they're all together. I'm going to go on down to your electrolytes with your sodium imbalance. Remember, sodium impacts your brain volume, meaning that the fluid level of the brain itself. The brain is bathed in cerebral spinal fluid, CSF. It has some salts in there. It has some glucose that surrounds the brain. And when the person has a sodium deficit or they have too much sodium, it's going to affect whether or not the brain shrinks or it swells. High sodium, 145 milliequivalents in the blood, if it's increased due to vascular volume or edema or pulmonary edema is present, it's going to result in altered level of consciousness. You will see early on that the person will have muscle twitches and irregular muscle contractions. Late symptoms are muscle weakness and loss of deep tendon reflexes. You're going to have a patient that's agitated, confused. They may have seizures, lethargy, extreme thirst. They're going to want to drink. Decreased urine output, dry, sticky tongue, and mucous membranes. They'll be dry and flushed skin. And their specific gravity of their urine is going to be elevated because they have too much sodium. Okay, now low sodium is less than 135. If normal volume, then pulse rate will be rapid, but they will have a normal blood pressure. As the volume decreases, meaning they get to 128, 127, 126, 5, 4, 3, 2, they're going to
Yes,
have
please.
weak, thready, rapid pulse and hypotension, flat neck veins, meaning we can look at their carotids and their jugular veins on their neck, and we're going to see that they're flattened out. If there is a high volume, meaning that they have they're volume overloaded, but they're also sodium deficit. They're going to have a rapid bounding pulse, but their BP is normal or elevated. Their respirations is going to be shallow. They're not going to have very effective movement of their lungs because of the diaphragm is not able to fully pull in oxygen and get the lungs working. That's a late sign. Mild symptoms of headache first, and then personality changes, confusions, seizures, and then late is a coma. They may have nausea, abdominal cramping, diarrhea, and increased urine output. Okay, going to take a breath here for a moment. Cardiovascular, our number one cause of atherosclerosis. Say that one 3 times fast. Atherosclerosis is your cholesterol that lines the blood vessels. It's the most common cause of peripheral artery disease. So if someone asks you what is the most common cause of PAD or peripheral artery disease, we would say atherosclerosis or cholesterol that's in our system, because it leads to decreased blood flow. Remember, perfusion, cardiovascular. The prevention is to make sure that the patient is monitoring their serum lipids, that they're looking at their LDL and their cholesterol levels, and they should be using what meds? Anyone want to say? Okay. And by the way, when I said the calcium 7.5, that was because at 7.5 you see a lot more symptoms. 8.5 to 10 is your normal, but as calcium gets down to 7.5, you really start seeing symptoms with the low calcium. And that is a repeat of the Saunders on electrolytes. That's on page 91. 85 to 91, 92, 93. So take a look at that if you have Saunders. Let me see here. Cardiovascular heart failure. Okay, again, I'm going to repeat this again for you. Right-sided heart failure. If you have a question on your exam that says, which one of the following are the symptoms that we see with right-sided heart failure, please make sure to choose the edema in the legs and ankles, weight gain, edema of feet. Your number one sign is that edema and weight gain. And how do we, and I can't spell weight. I need to put a T in here. I'll correct that now. That's because I was typing fast. Weight gain, edema or of the feet. Left-sided results in our fluid backing up to the lungs. So we're going to see more dyspnea with that and problems breathing. Late signs with pulmonary edema is going to be that pink frothy sputum, but we don't see that with right-sided failure. That's left-sided failure that you see that, especially with worsening pulmonary hypertension. So make sure that you know which is right, which is left. Okay, switching gears again here. We've just left the cardiovascular system. If you know everything I've just went over for the cardiovascular and electrolytes, you should be fine with this exam. Vision, glaucoma. Again, glaucoma is caused by increased IOP or intraoptical pressure. That's our pressure that's inside our eye. The patient is going to have eye pain, blurred vision, peripheral vision loss. They're going to see halos around lights, but no blind spots. That's with diabetic retinopathy, when the patient has holes or macular degeneration. They're going to have holes in their vision. So again, know that it's increased eye pressure, blurred vision, peripheral vision loss, and halo around the lights. People that have glaucoma, they have eye drops that are administered for the rest of their life to decrease that pressure. Our medications to treat, again, glaucoma, make sure that you know to be able to choose these. That's mannitol, pilocarpine, and latanoprost, or Xalantane. If you know those 3 medications, you're good to go with your glaucoma meds, and you'll know which ones to choose if they have a multiple choice question that says choose all of the following that are used to treat glaucoma. Know the difference also about cataracts. Our cataracts, person has that film over their eyes, they have misty vision. and that's due to the opacity of the lens that is now more like looking through milk glass. Cataracts are do increase as we age. Cataracts may form because the person has diabetes. After surgery, we want to make sure that that patient does not lift more than 10 pounds and that they do not bend over. We don't want them doing anything that would increase again the pressure in their eye. It can actually cause the lens that we've just brand new placed into the eye to not heal correctly. We don't want them to rub the eye. We do want them to wear a patch or a guard at night and to wear sunglasses to protect their eyes from sunshine and bright sunlight rays that can cause pain. We do want them using stool softeners again to prevent constipation because we don't want them bearing down or to increase that pressure in the eye. They will use Tylenol for pain meds, and then, of course, their eye drops as instructed. They typically use those eye drops for about 10 to 15 days, I think, is about the average, about 15 days until it's gone. Okay, let's leave vision. Any questions about vision any further? Okay. Nursing skills. Make sure that you review your nursing skills in your red lab book. Look at the wet to dry dressing change. There is a question on the wet to dry. We want, again, wet to dry, we want to have that dressing get dry so that we can pull it out and pull to debride the tissue and debride the bad dead cells that are in that particular wound. We don't add saline back to that to loosen it up to make it easier to pull out, because then we defeat the whole purpose of doing wet to dry dressing changes. You do secure that dressing with a window pane tape. We do measure the length, depth, and width of the wound in the centimeters. We do position the patient so that when we irrigate the wound, we're irrigating from the clean inside of the wound, and then it's pouring outward down the skin into our collection basin or our towel or whatever we're collecting that drainage with. So we're cleaning from the inside, clean area, to the dirty. We don't want to go from dirty to clean, because then we would contaminate the wound further and cause further infection issues. Make sure that you know the proper steps of anchoring a Foley for male and female, and which step comes after each other. What step is after? Make sure that you know that once you've advanced the catheter and you have obtained urine, you see that you have obtained urine, then you're furthering the advancement of that catheter another 1 to 2 inches for females, and males up to another 4 to 6 inches, and make sure that we taught going to the bifurcation, and then you anchor the balloon. So we want to next fill the balloon with the required amount of water, either 5, whatever it says on the packaging, up to 10 mLs. Make sure that we
I have a question.
yes.
I thought for males that it was from 3 to 4. So is it 4 to 6 or 3 to 4?
You want to make certain that you're getting that in all the way into the bladder, because if you fill the balloon up and it's short and that person has a longer urethra, then we've got a problem. We're actually trying to fill a balloon up inside the urethra instead of the bladder. I think you would still go by what your manual says, but that's another reason why when we were teaching this, we said go all the way to the bifurcation, or do whatever according to your policy at the facility where you're working. I've always gone to the bifurcation because it doesn't take any more ability to put that in all the way and making sure that the balloon is completely cleared the urethra and that you're in the bladder. Because I have unfortunately seen people who it's hard to tell 3 inches. It's hard when you're inserting. You don't have a ruler there. You don't know if you've gone 3 inches or 4 inches. It's just to be on the safe side. Make sure that you get it in. With females, it's 1 to 2 after you see the side of urine, but just making sure that we're getting that particular balloon it filled when we know that we're in the bladder is the most important thing. Otherwise, you end up with damage. But again, yes, I think your manual does have a different 3 to 4 or something of that sort. I never felt that that was probably enough. But for the question on the test, it's going to be more based on females than it is on males. So just saying, it's good to know both,
Okay,
but
thank you.
definitely know the female. So what other, with males who have BPH or enlarged prostates, we can use a Coude catheter. Do know that the Coude catheter is a little bit stiffer and it's bent in a special way so that we can get it through the enlarged prostate and through the urethra into the bladder. We can use a condom catheter on males. It's not for females, of course. We want to make sure that we keep the Foley catheter below the bladder. And number one is to make sure there's no kinks in the tubing. Make sure it's not bent. Make sure it's flowing freely. Otherwise, if it's kinked, then it's not flowing into the bag. One of the first signs of BPH, again, BPH, benign prostatic hypertrophy, is the first sign is slowing of the urine flow, meaning that the flow is not that good because of the swelling of the prostate. And of course, the prostate is a walnut-sized tissue that surrounds the urethra. And as it swells, it's pressing up on the urethra. So urine flow would not be very good if that is swollen. So it's kind of common sense. Remember your medications, Flomax and Proscar. Keep the flow, Flomax. Kidneys, need to know that 30 mLs of urine per hour is what we need in order to remove waste from the body. Lower than that, it's called renal failure because they have anuria. They're not producing enough urine. Renal failure, if not treated, will result in electrolyte imbalance. It results in fluid overload and metabolic acidosis, meaning the HCO3 will be lower than 22 and the pH will also be low. So if you have a arterial blood gas and you know that the person has a metabolic acidosis due to renal failure, then we would look for the pH that's low. We would look for the HCO3 that was low. Definitely know these words. Know the terms. Anuria, little to no urine. Dysuria, which is painful or burning during urination. Polyuria, production of too much urine. And hesitancy. It means that they've got a good urine flow and then it slows or stops and it's hard for them to get it started back up, and it's called hesitancy. Know your normal urine anatomy. Know that all parts of the kidney system plays a part, but you need to know the direction things flow. It goes from the kidneys to the ureters. Don't get the ureters and urethra missed on this question. You'll have 2 ureters. You'll only have 1 urethra. So the kidneys, you have 2 kidneys. So we have ureters that go from each of the kidneys, then into the bladder where it's collected until we eliminate it through the urethra and out the body. So I purposely put in more wording behind this so that you can say, oh yeah, which way does it go? Kidney, ureters, bladder, urethra. Okay, again, delegation. Do you know, again, I'm hitting this again because there was a couple of questions, like 2 or 3 on delegation to the UAP, especially on patients who are going to surgery. The LPN or RN, they need to be doing the assessments. They need to be looking at the skin. They need to be doing the teaching. They need to be doing the physical assessment. You can only delegate those tasks to the UAP that is normally within their scope of them being able to carry out. You cannot delegate the tasks that are part of the nursing process, which is assessment and diagnosis, or nursing diagnosis. We want to make sure that we're only doing what they can. Now, they can help you with vital signs. They can help put on lotions. But when it comes to teaching incentive spirometry or teaching and explaining and obtaining consent, then we need to make certain that we are giving the patient all the information and that we're documenting that education that was provided and that we taught them how to do IS, incentive spirometry. Okay, sometimes we'll have a patient that has cancer, or they may have osteoporosis also. We call it a pathological fracture because it's and not a fracture due to a fall. It's not a fracture due to an accident or some type of injury. A person can be just sitting in a chair and have a big cough, and they break the ribs because they have brittle bones. And of course, cancer patients can have that happen to them because they're on different types of chemotaxic drugs like chemotherapy, or they may be receiving radiation therapy, or they may have bone cancer. If they have bone cancer, then they can have a pathological fracture. And again, that's a fracture due to cancer or disease process, and it's a spontaneous fracture. There's no cause for it. So that may be due to just a sudden movements, again, like cough, such as in the rib fractures, or hip fractures due to stress, but no fall. So know that if you have a patient, this is the assessment you're going to do. Was there a fall? If there was no fall and they have a fracture, then it's probably pathologic. Okay, arthritis. Arthritis and rheumatoid arthritis, we're going to be kind of moving into some questions with those. Arthritis, of course, is patients with osteoarthritis. That's the wear and tear of the joints, like the cartilage is being worn away, and now we have bone on bone. We would see patients that have arthritis of the hands. They're going to have those Heberden nodes in the finger joints. They might only have unilateral joint involvement, meaning it's only on one side or the other, and they'll have localized pain. That pain is going to be right where that joint is. It's not going to be systemic, meaning everywhere. Again, rheumatoid arthritis, though, affects all the joints equally, sometimes at the same time. Arthritis or osteoarthritis, again, can be just one knee joint or one elbow or one shoulder. It can be both. I'm not saying that I happen to have arthritis in both my knees. One was worse than the other, so I have had a right knee total knee replacement. But I'm hoping I don't have to do that left knee. I tell you, that was extremely painful, probably one of the most painful procedures I've ever had. So that person will have pain and stiffness, and arthritis is usually worse in the mornings on waking, but then as you move around and keep going, it actually decreases. And then when you sit down and you're immobile again, as you end up stiff again and you have to get up, that's usually from arthritis. Again, I've got here a number E, joint pain due to wear and tear of the cartilage with bone-on-bone erosion. So what can we do to reduce the risk of osteoarthritis? We would want to limit our alcohol use. Do weight-bearing exercise. We want them to stay active. Stop smoking. Every answer that we have on this test is going to be stop smoking somewhere along the way in a lot of these. Keep your weight in normal range so that you're not wearing out your knees and your hips and your joints so quickly. Another form of arthritis is uric acid that is built up into the joint, and it's called gout. It's a different kind of arthritis. It has more inflammatory process. It's similar to rheumatoid arthritis, but not as much close to osteoarthritis. You'll see patients that have gout that also have congestive heart failure. Gout is inflammation of the joint and bursa with a collection of uric acid crystals that build up in the joint space. They'll have a deformity of that joint, and it's kind of a soft tissue-like look. The toe or the joint where it's at, it will be red, inflamed, and painful. It can be also worsened because of the consumption of alcohol, red meat, seafood, sugary drinks. Obesity, high blood pressure, kidney disease will also worsen this. And of course, it's linked to genetics. So if you have a family history of gout, then it's a possibility you could have gout too. Rheumatoid arthritis, on the other hand, that's more of a systemic autoimmune condition, and that affects joints. The fingers and toe joints will be bent and contorted. It's autoimmune. It's our body attacking itself. multiple medications out there that are injectable. These patients can go in and have a lot of the MAB or IB medications, which is the immune modifying medications to shut down the immune system to help slow the progress of rheumatoid arthritis. Rheumatoid arthritis, you can also see that in all different age groups. But as we get older, arthritis is going to affect the older adult more, but we'll see rheumatoid even in younger people in their 30s and 20s. Okay, compartment syndrome. Remember the urgent assessment. If you have a patient that has a cast or they've had an injury and they have lots of swelling in their arms and legs, or the arm or a leg, remember that compartment syndrome may present with sudden increased pain. We may have given this patient pain medication 20 minutes ago, and now suddenly they're complaining of huge amounts of pain and they have swelling, and we can see that they have the 6 or 7 P's that have changed. Remember, the P's are pain, pallor, paresthesia, paralysis, poikilothermia. That means color, temperature changes. So one of the first things we're going to see is pain. That's the earliest sign. Late sign is loss of pulse or loss of blood flow, and we don't want it to get to that. We're going to want to assess that earlier. So if they have a cast on their arm or leg and they have swelling with it, we want to make sure we get that elevated. We want to get ice on it. We want to keep them from having too much swelling. If the swelling gets worse and we're assessing the fingers or the toes and they feel cold and they're purple and there's not enough blood flow, we need to get someone in there to actually cut that cast apart so that we can allow blood flow again. The treatment for compartment syndrome is a fasciotomy. That's where they go in and release the fascia surrounding the muscles and allow the blood flow to then go through. And it is a surgical procedure. We showed that in our labs in Indianapolis. So if you haven't seen that, there's some good pictures of that on YouTube on how that is taken care of. Number one best way to prevent infection: wash our hands. So we want to reinforce our UAPs and other personnel to make sure that they're washing their hands. They should be washing their hands as they're entering the room and then upon exiting the room. So every time you put on gloves and you take gloves off, you should be washing your hands and then donning new gloves if you need to. When we're switching out gloves and stuff, making sure that we're keeping our hands clean. If this person has C. diff, though, the only proper way to wash your hands is with soap and water. Do not use alcohol-based hand rub because it's not sufficient to kill off the Clostridium difficile bacteria. Okay, make sure that we're also reinforcing that with the family and members also, because sometimes families will come and visit and they won't wash their hands. So let's encourage them to wash their hands too. Do you know the difference between sanguinous, serosanguinous, serous, and purulent? If you know that sanguinous is bright red and you know what it looks like, if it's on a dressing, then you're going to be fine for this exam. Remember, we had that picture on one of I think it was our lab test, and it might have been our second exam, somewhere around there, sanguinous dressings. So that's going to come and revisit you again for the finals. So there's a number of questions that are coming from the previous exams and the previous quizzes. One of the new topics in this one is going to be hemophilia. Know that hemophilia is a bleeding disorder. There's 9 different clotting factors that the person could be having issues with. It is because their clotting factor, they're missing something. They're missing something that causes their blood to clot, and it can be inherited. The treatment for the hemophilia is, of course, to administer the missing or deficient clotting factor. So we're going to actually give them whatever they're missing. If they're missing clotting factor number 4 or 5, Leiden deficiency is number 5. We're going to actually give them the clotting factor that they're missing. Our signs and symptoms that we need to watch for is they will have increased bleeding from the gums when brushing their teeth. Frequent nosebleeds that occur spontaneously for no reason, tendency to bruise easily. If they're having bleeding into the joints, they're going to have joint pain and stiffness due to that bleeding into the joints. Remember again that hemophilia, that the treatment is give them the missing clotting factor, give them what they're missing. Remember PT and INR? Yeah, that's that test we do for warfarin. Make sure that you know that the normal is 11 to 14 seconds for that PT. People that have hemophilia, the normal bleeding time is 11 to 14, but these people are going to bleed longer. It's going to take them 30, 40, 50, whatever their clotting time is. It's going to be a whole lot longer than that 14 seconds for them to start clotting. The other blood disorder we discussed this term. Okay, it looks like I've got a problem with my internet again. Sorry. Let's see if this will clear up. Again, if you lose me, let me know. Again, sickle cell is our other bleeding disorder that we had problems with. Sickle cell is the irregular shaped, sickle shaped red blood cells of our blood, and it can clot together, blocking blood flow from our capillaries and small vessels. The number one symptom is severe pain. As long as you remember that, you should be fine. Severe pain with these patients. DVT, since we're talking clots, we might as well go on to DVT and thrombus. Never massage an affected extremity that has a blood clot in it. All you're going to do is cause that blood clot to break off, go to their heart, cause a heart attack, go to the brain, cause a stroke, or go to their lung and cause a pulmonary embolism. Do administer anticoagulants. We will be giving them heparin or Lovenox injections. They will be probably on Eliquis or warfarin or rivaroxaban, depending on what they can afford, for a number of years to cut down. If they have AFib, they definitely need to be on an anticoagulant. We do put on TED hose or anti-embolism stockings. TED hose are the white hose that are constricting that help with blood flow return. Or we use SCDs, which is the sequential compression devices that are like little pillows that blow air in and massage or kind of gently move those blood vessels to allow the blood to keep flowing, especially on those patients that are immobile. If they are bedridden and they're not getting up and moving around, then we've got a problem. I think my video camera just now came back on. So hi, how are you guys doing? The extremity signs and symptoms with DVT. It's going to be increased leg swelling, and then it's going to be warm in the area of the clot. And if it's in the calf, it's going to be in the calf. The pulses may be difficult to feel below the blood clot, depending on which vessels it's actually in, or if they may have congestion of the blood flow, swelling, etc. When we have them dorsiflex is where they point their toes up to the ceiling. If they have increased pain in that calf, or if they stretch out their arm and they have increased pain and stuff in the biceps or wherever that blood vessel clot is, then that's where it is. We're going to want to elevate the extremity. And then again, we're going to give them anticoagulants. They're going to do an ultrasound, see exactly what type of clot we're putting up with. Remember, if they have a DVT, there's possibility they could end up developing a pulmonary embolism too. So priority action, number one, if we think or suspect a PE, we're going to put them on oxygen. Help always airway. Set them up, make sure we get them on some oxygen. And they're going to have a quick change in their respiration. They're going to say it's completely, like stabbing immediately into the chest. Every time they take a deep breath in, it's going to be painful. They can have difficulty breathing. One of the blood tests that we do is a D dimer. If that test is elevated, then we know that they have a PE more than likely. We're going to send them down for ultrasound. We're going to do a CT scan or something of that sort so we can actually evaluate that area. Get them onto anticoagulants. They may need to be on those anticoagulants for 12 months to up to 2 years or longer, depending on what the doctors say. If they have AFib, they're going to be on it for lifetime. Increased risk factors, again, if they've had a previous DVT or presently have a DVT, we need to be watching, make sure that they don't have sudden respiratory lung pain. If they have that, then that clot is broken off and it is actually moved. They could also have an MI. They could also have a stroke. So we need to be watching them. These people are the ones that are on prolonged bed rest or immobility, and they're not keeping their TED hose on, or they're not keeping their SCDs going. They need to understand that the SCD, yes, they may be warm, but if they're not getting up and moving or walking, then they need to be having those on to keep them from getting a blood clot. There's also a higher incidence of DVT and PE with patients who've had recent orthopedic surgery, those patients that have recently had their hip replaced or their knees replaced. Okay, remember that I think there's 7. There were originally going to be 10 med questions on this exam, but I think they've cut that down to 7. Make sure you are labeling accordingly. You're putting milliliters with milliliters, tabs with tabs, capsules with capsules, that you are doing drip rate with drops per minute. Read the question. See what they're saying. We tell you what to label it. Just read it, please. If they are asking you how many for the total day and the person is taking 4 tabs each dose, and they take it 3 times, that's going to be 12 tabs. If it's 2 tabs and they are taking it 4 times a day, then that's going to be 8 tablets. So make sure that you're multiplying by the number and know what you're being at. Are they asking you per dose or for the full day? Sometimes we make the simplest mistake because we just don't take the time to read the question well. You're going to have plenty of time to do this exam. 100 questions, you're going to have a couple of hours to do this, okay? So you're going to be okay. Just make sure that halfway through you look up, make sure you're halfway through. Make sure you're on question 50 by about an hour into it, okay? What are your antidotes? So make sure you know your medication antidotes. Protamine sulfate is for heparin and Lovenox. Those are your blood thinners. Vitamin K is for warfarin. Narcan is for the opiate overdose, for people that are on Narco or Lortab or morphine and they're not breathing very well, so we give them Narcan. Make sure that you know the laboratory testing. PT and INR is for warfarin. Know the normal range, 11 to 14 seconds. PTT is to monitor heparin. And let me see if I've got some more down here. Yes, BUN, blood urea nitrogen. That's monitoring our kidney function. If high, the person is dehydrated. If they're low, they may be volume overloaded. If their creatinine is on its way up, normal is about that 1.2 at max. When it starts getting 2, 3, when you get up to 4, that person needs dialysis. Our CBC, that's our complete blood cell count. That's got a lot of different elements to it. One of them is RBC, which is the red blood cells. Know that we look at that along with the hemoglobin and hematocrit. If those are low, the hematocrit and hemoglobin is low, then that person probably has anemia. If it's too high, they have polycythemia, or they're producing too many red blood cells. Know that the number 1 sign of an infection is elevated white blood cell count. And the one that goes up with the white blood cell count is your neutrophils. So your neutrophils will be high and your white blood cell count will be high. That tells us, yes, they have a bacterial infection. If their eosinophils are high, if they have asthma, then that tells me that person has eosinophilic asthma. Okay, I am hearing someone's phone, and I thought I had blocked everybody's or muted everybody's, but I'm hearing somebody's audio. Make sure that you have muted your sound, please. Okay. All righty. I am so sorry, but I am. Okay. Laboratory point of care. Okay, platelets. That's where we left off. Platelets, if the platelets are too low, then that person may not be able to clot as well, especially after injury. If it's too high, they may throw clots. So that's the reason why we look at the platelets. Okay, point of care testing, glucose testing. If you are training your unlicensed assisted personnel, you would know that you need to retrain them if they're not doing that correctly or according to your procedure and policy for your facility. With most of these monitors, we're wiping the finger with alcohol, allowing it to dry, and then we're using a nice little Sharpie lancet that is new for that patient. We're using the sides of the finger or the pads of it, not the tip, but just the sides so that they can get a good blood sample. And we're wiping that first blood sample off. So make sure we're wiping the first blood sample off. And then we're using the second blood sample in order to do our testing. We don't want to overly milk or overly press the finger when obtaining that blood sample, because if we press too hard or too much on that finger, then we're going to get juices from the tissue that's going to dilute our blood sugar, and our blood sugar is not going to be valid. So make sure that they are doing their checks right. It is the LPN and RN's responsibility to make sure that the people that are working with us that are unlicensed are doing things correctly, because we're responsible for them. They're on our license at that point. Isn't it scary to think that somebody else may affect our licensure? And it is a little scary sometimes when I think about that, especially when you're going into the clinicals. The teacher that you are with, you're under their license at that time. They need to make certain that you're doing things appropriately too. So when you have your license, it's your job to make sure that everybody's doing their tasks correctly and that you've retrained them as needed. Okay, post-surgery. Teaching assessment. Make sure that you are encouraging your patient to deep breathe and cough. You want to clear out those lungs from the anesthetic that they are using. Make sure they're using their incentive spirometry while awake. They should be using it 8 to 10 times every hour while they're awake to keep them from getting pneumonia and to also clear out the anesthetics. They should make sure that they're using their SCDs. Again, I'm hitting this again. There's a couple of questions on SCDs and anti-embolism and DVT. So make sure that they are using their SCDs, sequential compression devices, and TED hose. And we can actually stop that once they're ambulating well, where they're getting up and they're walking through the day quite often. But if they're not ambulating, then they need to be wearing those. We also need to make sure that when we get them up to ambulate, that they're using good shoes, good tied shoes that are not going to slip. Make sure that it's non-skid. Remove the obstacles around them that might obstruct their paths, especially if they're using a walker or an assisted device. Encourage rest periods. Don't use the walker on stairs or escalators. Do not use the walker on stairs or escalators, and that they should always take that device with them. If the patient has just had a hip replacement or a knee replacement, says, well, I don't really want to go down the hall with the walker. Can I just walk? No, you use the assisted device because it's there for your safety. Make sure that we've taught the incentive spirometry appropriately. We want to make sure that this patient is sitting upright, not supine. They shouldn't use it while they're laying in bed because that's not moving the secretions in their lung well enough. Teach them to breathe in, not blow. Do it slowly so that they can see that the little device is registering appropriately. And again, 8 to 10 times. I won't go over that again. I think I've mentioned it now 3 times in here, but I think that was how many different questions there were on that. Assessments, remember your 6 Ps. Again, pain, paresthesia, pallor, paralysis, pulselessness, and poikilotheria, which is temperature coldness. Mobility interventions for the older client encourage range of motion, change their position every 2 hours, keep their skin clean and dry to prevent skin breakdown, and ensure proper body alignment. Again, we did this in quiz 3 just recently. Again, some of these questions are going to be revisiting you. Safety, prevent falls, especially for the post-op patient with a hip or knee procedure. Have them sit on the side of the bed and dangle their feet for a few minutes before they get up to start walking. Make sure they take a few deep breaths. That actually helps their blood pressure stay up. And make sure they are not dizzy. If they're dizzy, have them set right back down. Okay, let's talk about safety again. Near miss. Do you know the difference between near miss, sentinel event, and serious adverse event? Do you understand? If you don't, go see Giddens, third edition, page 429. The sentinel event, that is an event that resulted in severe or permanent harm or death. Those are the ones that we're going to have an immediate root cause or risk cause analysis. Root cause analysis in RCA. We're looking at what caused this. We want to eliminate that error from happening ever again. So that's the reason why sentinel events do signal a need for an immediate investigation. It's not to put blame, it's so that we can say, okay, was it a equipment error? Was it a process error? Is it a procedure error? What caused this person to die? Is it something we need to teach or something that we need to do different? Again, we try not to put the blame on human beings. We only put the blame on human beings when it actually resides there. Near miss, that is an event that you catch before it ever, it did not reach that patient. As long as you understand near miss, it means I caught it. It didn't touch the patient. I found out I had the wrong med or I pulled Fosamax instead of Flomax. Yeah, we don't want to do that. We want to make sure that we catch those before they get there. A lot of our machines today limit what medications that have the same or similar names that are next to them. So that kind of keeps us from pulling or having that error. Okay, post-surgical client. If you have a post-surgical client that has had a hip surgery, they should be limiting their time in the chair for the first week for about 15 minutes at a time, and then they should, try to rest. Make sure that we're noting if the patient is getting the wrong directions from the CNA or the UAP. If the CNA would go in and tell the person, here's your call light, call me in 2 to 3 or 4 hours and I'll get you back to bed. Or if they were to say some things like B, C, D, and E, then definitely make sure that you are retraining that UAP or CNA. Make sure that they know what the correct thing is for that hip surgery patient to be doing. The hip surgery patient should not be sitting in a chair that's real low because they can pop their hip out of place. They need to be sitting in a chair that's higher. They need to make sure that they're not in a high Fowler's position in the bed because that lowers the angle between the chest and the hip. And then again, that can cause the hip to actually dislocate. Do you know the differences between primary, secondary, and tertiary preventions? If I'm sending a patient or referring a family member to an Alzheimer's support, then that's a tertiary prevention. You need to know the differences between primary, secondary, and tertiary. Vital signs, know your assessment results for vital signs and which ones would require you to actually review or recheck. If you have a CNA who says, I checked Tom's blood pressure and it was 178 over 110, and they didn't recheck or didn't go in, you need to go and check that. If they say their blood pressure was 132 over 84 when we got them, when this morning, but when we got finished walking him, we checked the vital signs and his blood pressure is now 102 over 60. You may want to go back in and check that. Make sure that that patient is okay and stable and that something hasn't changed. So know which vital signs will make you go back in and check those patients or to recheck the vital sign to make sure it was right. Sometimes I'll look, the best action is for the nurse to know where the blood pressures have been running for this patient. And if something is abnormal, then to go back and reassess. Know where if their heart rate has been normally stable in the 80s and 70s, 80s. Now that we've got a pulse rate of 120, 130, it's not something's changed. Do they have a fever? Let me go in there and assess. So it's up to you as the LPN to know when to go in and go reassess that. Okay, let's talk ABGs real quick here. I hope you guys have been really practicing your ABGs. I don't care, as I told my people, I don't care which method you use, whether it's the Rome method, tic-tac-toe, or the marching band method. All of those are available on YouTube. If you don't know it now, you need to make sure you've got it in hand because you're going to have a number of questions that's going to be going over here's what's going on with the patient. So which ABG would you expect to see? Which is the appropriate ABG you would expect for diarrhea? Which one would you expect for a patient that had COPD? Which one would indicate the patient has hyperventilation? Which one is the one that the patient has low and slow, they're sedated, or they've taken far too many narcotics, or they've taken a drug overdose? What would we expect on the ABG? Remember, rapid breathing is blowing off CO2 that causes respiratory alkalosis. That means we're blowing all that CO2 off. Also, don't make this harder than it is. If an ABG result or ABG, they're talking about respirations, they're talking about the person breathing, that they are having dyspnea, that's respiratory. Everything else is metabolic. If it's vomiting, if it's diarrhea, if it's their urine, if it's diabetic, then that is metabolic. If it doesn't involve respiratory, then it's metabolic. Nice and simple. Okay, then it's the HCO3 that we're looking at. If it's respiratory, it's the PaCO2. It's the CO2, carbon dioxide. PCO3, base, that's alkaline. So therefore, know what you're looking for, okay? Again, do your pH first. If your pH is low, then we know that it is acid. If your pH is high, it's alkaline. And then see which one is going with the pH. Is that because respiratory is acid, or is it respiratory is alkalotic? Is it because base is acid, or is it because base is alkalotic? Then we know that it's either metabolic or respiratory, whatever it is, acid or alkalotic. So just practice those. If you have to, go on YouTube and review those videos today. Make sure you have that in good hand because we're building on this. You've got to know this because the third term, guess what? It's going to come back at you. This is not one and done. If you do not know your ABGs, you're going to have problems in third term and fourth term because guess what? Lots of questions on ABGs in third and fourth term. Okay, pain meds. If the pain med is, if a patient is asking for pain meds, PQRST. Go do your assessment. Figure out what is the appropriate. Go look back up at the medication hints and know which med to use. Know your signs and symptoms of osteoporosis. If you need to, look at Cooper, page 1347. What is the contraindications for hip fracture? Do not sit at high Fowlers. That decreases the angle of the thigh to the chest. It can pop out the socket. UAPs cannot be delegated the task of charting, I should say, or changing the surgical dressing. They cannot assess the skin. As that assessment is the licensed nurse and the registered nurse's responsibility, not an unlicensed person. So they should not be changing the surgical dressings. Intake, output. Know which part is intake, which is output. Where would you record those? If it's urine, it's on the output. If it's IV fluid, it's on the intake. Okay? Nasogastric NG medications, know how to deliver that medication. We deliver one med at a time. We're going to check the residual first. We're going to return the residual to the stomach. It's not ours to keep. Don't throw it away. Don't put it in the trash. If the residual is too high, we're going to be notifying the provider that the residual is more than we expected. And we're not going to give those meds right now. We're going to hold on to that. We may want to wait 30 minutes and then go check the residual again. If it's still high, yes, then give that provider a call. Check the placement to ensure that the NG is in its proper position. Make sure that you're evaluating if the NG has not shifted, has not been pulled out of the nose. Make sure that the PEG tube or the J tube and or the G tube and everything is where it's supposed to be. Make sure it's not been pulled out. Conductive hearing loss. It's also known as obstructive hearing loss. Conductive is what we hear through the air. It's caused by the sound waves being obstructed so they cannot be transmitted and understood. Conductive hearing loss means that there is no damage to the cochlear, etc. It's that we just cannot hear it due to conductive issues. Okay, kidney. Reabsorption is the primary process of returning our elements, sodium, potassium, etc., to the bloodstream, such as glucose, sodium, and potassium. Kidney reabsorption is the primary process of returning elements to the bloodstream, such as glucose, sodium, and potassium. And I need to put an S behind this because it doesn't make sense when I say it out loud. There we go. Therapeutic communication techniques. Know your techniques. What is an open-ended question? Do not share opinions when you're talking with a patient. Allow them to talk. Sometimes silence is golden. Types of good beginnings. If you're going in to talk with a patient, is it okay if I sit with you for a moment and ask you some questions so we can get comfortable talking to one another? Is it okay if I talk with you? Can you tell me more about? Patient tells you something, then ask them the question. Can you tell me more about that? How do you feel, or what made you think that, or what made you be aware of that, so that you can learn more. Again, let them do the talking, and that way you'll learn more from their experience, from what they're experiencing. And then you can make opinions on what is going on with this patient. What is the assessment? Other techniques that you may see with therapeutic communication is restating and clarifying. Those are okay to use as well, but know when to use which one. We're getting towards the end here. Diabetes, diabetic ketoacidosis symptoms. Know that that is caused by a blood sugar of greater than 300. The pH will be less than 7.35, which is acidic. The person may have fruity smelling breath. Again, that sometimes is mistaken for the person being drunk. It can be mistaken for alcohol use because the fruity smelling breath smells like, if you've ever had fruit juice that's gone bad, it turns into alcohol, basically. That's the way the diabetic is going to smell when they have diabetic ketoacidosis. They'll have ketones in the urine. They'll have dry skin with sunken eyes. They may have that Kussmaul's breathing, which is their body trying to offset the acid by breathing out CO2 and alkalizing the blood. Again, Kussmaul's breathing is rapid, deep, and labored breathing. It's fast, very fast rate. Okay, look, speaking of diabetes, let's go over these real quick. If they have a blood sugar of less than 60, we know they're hypoglycemic. They're going to have dizziness, weakness, sweaty, confusion, nauseated. Remember the 15-15 rule, 15 grams of carbohydrate, and check. And yes, our Professor Jennifer said you can write out the ABG formula on our spare paper, and that is true. You can put actually the ABG pH, CO2, and CO3, and she did not consider that spilling. You can do that at the beginning of the test if you want to, apparently. That's what it says on the scratch paper that you will receive with our, now, I don't know if that's true if you're at a different school. In Indianapolis, we're going to allow you to do that. Okay, blood sugar's normal range, 80 to 120. Remember the 15-15 rule. If you have a hypoglycemic patient, we give them 4 ounces of juice, which could be orange, grape, or apple. Or we can give them 1 tablespoon of sugar, which is equal to 15 grams, or 1 tablespoon of honey. 2 tablespoons of raisins are also 15 grams. 4 ounces of non-diet Coke or cola. If they have glucose tabs, those glucose tabs are usually 15 grams as well to 20 grams. And then we want to follow up 15 minutes later and checking their blood sugar once more. If their blood sugar is coming up, then we want them to eat something like a sandwich or eat some type of a meal. And if they have blood sugars that are over 300, may not be good. They may need to seek direction from a provider. So you need to check orders. A postprandial blood sugar is a blood sugar that we check 1.5 to 2 hours after they've eaten a meal. It should be less than 180, ideally. That tells us if their meal content has been good. So postprandial blood sugars tell us whether or not they've eaten a good choice of food. It tells us about their meal time and the choices that they made. Fasting blood sugars, we usually collect those 9 to 12 hours after them not eating. So after, their last meal of the evening, then we get a fasting blood sugar 9 to 12 hours later. Know your insulins and your peak time. The most important one is the insulin onset, peak, and duration. Review your chart that was in the PowerPoint that we had when we went over blood sugars. Regular or short acting is 2 to 3 hours after administration is the peak. So really know the peak on that regular or short acting. It's 2 to 3 hours. Diabetes teaching, eating a balanced choice of protein, carbohydrate, fats, and minerals and vitamins are the goal of a good meal plan. And I think I've got a few more here on diabetes. Know the difference between type 1 diabetes, that's where the pancreas does not produce any. And no, I don't have time to review 163. I don't have access to 163, but just know that the older patients, type 2 is an older patient condition. Just know osteoporosis is an older patient's problem. Arthritis and rheumatoid arthritis. Professor Glaze did send out a review on 163 and medications for 163 last week. So check your email for those. Type 2 diabetes is linked to insulin insensitivity or poor production, meaning the insulin that we produce in our system is not being recognized by our cells, and we're not able to transport glucose into the cell. Type 2 diabetics can take oral or insulin to control their blood sugars, and these people are usually obese. Type 1 diabetics are thinner, and again, they will have symptoms. All diabetics have symptoms of polydipsia, polyphagia, polyuria, but your type 1 does not produce insulin at all. They're to the point where they have to have insulin to live. Neuro brain function, traumatic brain injury, severe, just know that if it's severe when you have, if you are unconscious more than 24 hours, if this person has been unconscious or has been in a coma and it's 24, 25, 26, 3 days, 4 days, 12 days, their prognosis is going to be poorer than the person that was only out for 30 minutes to 24 hours. That's moderate. Mild is 30 minutes or 15 minutes or less. Neuro and brain function, ICP, increased intracranial pressure. We don't want those people to blow their nose harshly. We don't want them to cough. We don't want them to strain when they have stools. We don't want them laying flat. We want to keep them upright. Our number one priority with TBI is to assess their airway, because if they start having airway problems, then we know that their injury may be affecting the brainstem. And those patients that have brainstem involvement have poorer outcomes and can die quickly. One of the first or earliest signs of ICP is going to be your change of level of consciousness. So, change of conscious. Late sign will be nausea, pupil sluggishness, or enlargement, and then not accommodating to light or movement. You know that when we check the eyes, we take a light and shine it in it. And if the pupil changes in size, we know it's the pupils are equal and reflective to light. But with a brain injury or brain trauma, then we're going to have a pupil that's going to be enlarged. Here we're talking the difference between adrenal Cushing syndrome. The signs and symptoms is hypertension, moon-faced, bruising, fragile skin, muscle wasting, legs are thin, but the torso is round and large. They have issues with hypocalcemia or low calcium. They have too much cortisol, too much overproduction of the adrenal gland. Result is that we do not want to give them prednisone. We don't want to give them steroids. They will have high blood sugars and they will have diabetes as well. And then the Addison's is the opposite. Addison's, they won't have enough cortisol. They are thin. They will have stooped. They will have other issues. Okay, talking perfusion. Again, remember perfusion is the movement of blood by our heart being pumped through our body. It collects the oxygen from the lungs and moves nutrients from the gut to the places it needs it within our body, from our fingers to the top of our head to the bottom of our toes. So anything that inhibits perfusion inhibits our ability for our life-giving oxygen and nutrients getting to those areas. Again, smoking. Us being sedentary decreases our perfusion. Hypertension, high blood pressure, elevated serum lipids such as LDL and cholesterol, and obesity. So if I were to ask you which of the following are limitations for perfusion or impairment, and these 5 were listed, you're going to be selecting those 5, right? Okay. Smoking, sedentary lifestyle, hypertension, elevated serum lipids, and obesity. Impaired perfusion, again, this is symptoms: pain, dyspnea, edema, fatigue, and dizziness. So when oxygen is cut off from an area, they're going to have increased pain. They're going to have shortness of breath. They're going to have swelling. They're going to have fatigue and dizziness. The apical pulse is checked at the 5th intercostal midclavicular line. You guys should know that. That was in term 1. So educating the patient, if they have hypertension, is very important for them to be taught to take their medication, that hypertension is the silent killer, and that they need to make certain that they're taking their meds, because if they don't take their meds, it's going to cause them to have enlarged heart. It could cause them to have kidney failure, hypertension, in other words. Again, the problem with patients who have hypertension is they won't take the meds because they don't feel any different when they take them or when they don't take them. Their blood pressure being high doesn't cause symptoms. They're asymptomatic. But blood pressure kills because, again, blood pressure enlarges the heart, because the more pressure the muscle has on it, the bigger the heart gets. Orthostatic hypotension. Do you have the patient change position slowly? Remember, it's a 20 millimeter of mercury drop in systolic pressure from laying to sitting or sitting to standing. So when we check them, they're going to have those issues with their blood pressure dropping. We should have them sit on the side of the bed and dangle for a few minutes, take some deep breaths before standing again. Same thing that we do with patients that are getting up for the first few times after surgery. Constipation, the best treatment of constipation is give them fiber, give them water, and have them move, have them walk, have them ambulate, because that keeps peristalsis happening in their gut. It keeps those intestines working. So again, the best treatment is to just get them ambulating, give them plenty of fluids, and give them dietary fiber. We try not to give them medications if we can possibly get out of it. Okay, GI, ulcerative colitis, frequent diarrhea with bloody stools is the symptom of ulcerative colitis. That's because the colon lining is irritated and raw. And it, of course, then produces more mucus, and then they will have blood in their stools. Again, it's from the erosion or irritation. The colon is responsible for reabsorbing water back to our system and compacting the stool. So if that's not happening because we have an impaired colon, then we're going to have problems with our fluid levels also. The small intestine, again, is responsible for nutrient absorption. Our foods break down when they enter the duodenum. The enzymes go into that area. As a reminder, reminding you that mobility, if we use a cane, we're going to put the cane on the strong side and it moves with the weak side. So if our left leg is the weaker, we just had left knee procedure, or if we had a left knee total knee replacement, then we're going to hold the cane in our right hand, and then we're going to move the cane forward with the left leg at the same time. The cane is to support the weak side, but we're going to hold it on the strong side. So it's a little bit different thinking. Remember, all the way back to the beginning of the term when we talked about mobility and we had our first quiz and we talked about canes, and that again, the cane is on the strong side, we move it with the weak side. Okay, and also, last but not least, know your Glasgow Coma Scale. How is it used? It is used to determine consciousness. Is this person conscious? Are they opening their eyes? Are they following commands? And we're going to give them numbers depending on how well they follow are they opening their eyes spontaneously, or are they not? Are they only moving towards pain or away from pain? Or are they following our best verbal command, or are they not following commands? Again, Glasgow Coma Scale is determining the consciousness of our patient. That's all I have. And I knew that this was going to take about 2 hours, about the same amount of time it was going to take you guys to take your test. Any questions, I'm going to unmute you. And if you guys want to speak one at a time, I'll be happy to answer any questions. Let me get up here and get you guys unmuted. If I can, let me see one of these here. Okay, I have you guys all unmuted apparently, so you're welcome. If anyone has a question, you're more than happy to answer those. Let me check to see if my email has a bunch of emails. Okay, I
don't have a question, but I do. Hello.
I have a lot of.
Can you hear me, Ms. McBride?
Yes, I do hear you. I am going to go ahead and send out. I will put this recording on SharePoint, so you guys can listen to it again if you need to, or SharePath or whatever, Evolve. Yes, go ahead with your question.
I don't have a question, but I do want to say thank you for everything. You have been great to us.
Well, thank you.
You really have.
You well. You guys are going to get A's for me, right?
Yes.
Okay, good. Because I want you guys to do well and stuff. If you have any other questions and stuff, I'll see you guys tomorrow. We're not doing the test until 2:30 in Indianapolis, so be there at 2. Be early. Please be early. It will give you time to kind of settle down ahead of time, get your computer together and go in. There's going to be 88 some people in that room, 87. We're going to divide you up in between 2 rooms. And so I'll be in one room with Professor Glaze.
So we got to be there at 2:30.
The test starts promptly at 2:30. What I mean, you should be in your seat and starting the test at 2:30. Do not come at 2:30. Come at 2.
Right.
Be there at 2. 2 o'clock at the latest. 1:45 would be even better. Because we're going to be starting testing tomorrow. I think our first group will be testing around 10:30 tomorrow. Then we're having test groups run right after the other all the way through Wednesday, and all 4 terms will be having their final exams this week. And then there's some makeup exams that we're also doing. Yeah, I do not have access to 163's test. They put me on to that particular class at the last like midway through, and they did not give me access to anything but the PowerPoints to be able to teach you guys. And I'm sorry, I wish I had. But again, your adult, elderly adult is no different than what we teach in 160. It's just that you have to apply it to the older adult. Is the same information a lot of times. I was looking at those. Now, I did on SurePath in Indianapolis. I did go through and take every last one of those PowerPoints and drive them through an AI and had them give me a study guide for each of those PowerPoints groups, like for week one. So it'd be a week one, lecture 1 and 2, and week 2, lecture 1 was on 1. I was able to get 3 PowerPoints evaluated by AI. And then those study guides are on SurePath. Go in there, look at student, go into SurePath. When you go in on the left side, it says content. It'll have those study guides on the left for 163. And then Professor Glaze also sent out that handout last week that went over math questions that you should be able to do, ABG practice questions, and then she also had topics. Okay. Yeah. So
Miss
yeah,
McBride, this is Jalen. Before everybody gets done asking their questions, can I talk to you about that email I sent you before you go, since I
the
actually
which
have
one?
you here?
The which
Because
one?
when I about my makeup exam, I did it,
Yeah,
but
I know.
it
Did you go
I
into
sent you 2
Evolve?
emails.
Yeah. Did you go into Evolve
Yes, ma'am.
and resubmit?
I can try to do that, but on the second email I sent you, it said that if you don't extend the deadline, it has to be a manual entry.
See, I can't do a manual entry because I can't see your test.
Right. So when we were doing it, as soon as I got there, the internet connection was bad. It literally wouldn't even let me update Exemplify. Me and Dean Bell went in the hallway, and she said the internet connection was bad. So that's when we finally got the green screen, and I just shut my laptop. But
Yeah.
then I got another one saying it didn't upload. So am I allowed to like go back in and try it myself? Is what
Yeah,
you're
you go.
saying?
Yes, you need to go into Evolve right now while I've got with you on the
Okay.
phone or on this. Go into Evolve and resubmit. If you
Okay,
don't
I'm grabbing my computer right now.
remember that green, I have to see the green screen to know that you guys submitted
Yes.
your test.
And I
That's what
got one. That's
do.
why I emailed you, because I got a confirmation email that it was uploaded successfully. But then, like 5 later, I got another email that said it
Uh-huh.
wasn't uploaded successfully.
Okay, so then
So I'm like, well, which one is
go
it?
back in and re-upload that one because I'm telling you,
Okay.
what is showing me right now, this second, is that you have not submitted.
Okay. And when I did, it also, there was an issue with the password as well. She had to
So
go
I
in
know
and find the
that.
password.
I fixed that. So that should
So
be
there
okay.
was a lot to
Yeah.
that at the beginning. So I am logging in right now. Let me,
Because
my
if you
computer
do it
here.
while I'm still on this presentation, I can tell you whether or not that's resolved.
Okay, cool. I am pulling it up now.
Thanks everybody for, coming on board. I think I had close to 50 some participants, so that was a pretty good turnout. And then I'll be shutting this down and then redoing this.